anatomy of the tumor dictates the approach, and how, we can either take a middle fossa or a retrosigmoid approach to approach these tumors. The most important part will be understanding the anatomy and the dura. With respect to that, the whole approach can be handled. So this is the trigeminal nerve as it exits from the brainstem, from the pons, just medial to the middle cerebellar peduncle here. You see it has a large sensory root and a smaller motor root, which is lying more medial to it. It exits and comes out and forms the cisternal segment in front of the pons. When it enters into the middle fossa from the region of the Meckel's cave, this is the dural relation. And now we will peel off the dura to see the whole anatomy of the trigeminal nerve from the brainstem to as it enters the superior orbital fissure, the foramen rotundum and the foramen ovale. So this is how it happens. So this is the region, this is the tent, you can see this. This is the region of the brainstem where the trigeminal nerve is exiting here. This is the cisternal segment of the trigeminal nerve. This is where it enters the Meckel's cave. This is the V1, this is the V2, this is the V3 as they enter their respective foramina. And this is the region of the petrous apex, petrous bone, which has been drilled. Giving a closer view, this is the region of the petrous apex, which will have to be drilled if you have to do anterior petrosectomy and go in the posterior fossa. We generally don't need to do that for a trigeminal schwannoma, as I will show you in the latter part of my presentation. So again, this is the tentorium, this is the third nerve, this is the fourth nerve, this is the internal carotid artery, this is the gassarian ganglion, this is the V1, V2, and V3. You can see this. The V1 and V2 form the part of the lateral wall of the cavernous sinus, whereas the V3 is distinctly out of the cavernous sinus. So once you remove the petrous apex, you see the whole anatomy of the trigeminal nerve beautifully. This is the brainstem. This is where it is exiting, the cisternal component, the Meckel's cave, and the ganglion, and the peripheral divisions of the trigeminal nerve. This is the superior cerebellar artery, and we will see more anatomy as we go downwards. So what is important while deciding the approach for trigeminal schwannomas, or what makes trigeminal schwannomas good tumors to operate? So this is the coronal section showing the cavernous sinus and the walls of the cavernous sinus. This is the sphenoid sinus. This is the carotid artery. And it is important to realize that there are three compartments here. So this pink that you see here is the lateral wall of the cavernous sinus. And this is the endosteal layer of the dura of the middle fossa. This forms the lateral part of the cavernous sinus. And within these two leaves of the dura, so there is a second layer of dura here, which is formed by the epineurium of the trigeminal divisions of the trigeminal nerve, that is the V1 and V2. And that is the second layer that is formed here. So basically the V1 and the V2 are interdural. They are between two layers of dura. And this is the whole concept of surgery of trigeminal schwannomas, because this is the layer that will not transgress and let you go into the cavernous sinus. And here you see this is the third part, that is the region of the cavernous sinus, and this is the internal carotid artery. So looking at it from the ostial, from the bony view, so you see this is the anteroclinoid process, the optic struct, this is the region of the cavernous sinus, and these are the layers of the dura. So this is the endosteal dura, this is the layer of dura, which is the epineurium of the trigeminal nerves, and this is merging with this endosteal dura, and this is where the trigeminal schwannomas will reside. And this is the last part, this is the region of the cavernous sinus. I would like to believe, I work with Professor Goel, and we have done a lot of huge experience of trigeminal schwannomas. And as to answer the previous questions, if the tumor is in the cavernous sinus, it would be more likely to be a sixth nerve schwannoma rather than a fifth nerve schwannoma, because we have not seen any of it that encases into the cavernous sinus. Now coming from the posterior fossa, here you see the sixth nerve, the part of the dura of the posterior fossa has been removed to show the basilar plexus. This is the fifth nerve that is entering into this region, that is the Meckel's cave region, that is a depression on the petrous bone. And you see it carries its layers of dura. So the epineurium, it carries its layers of dura as it goes into the middle fossa, forming the basis of the interdural approach. So again, this is the anatomy. This is the third nerve, which is again forming and entering into the roof of the cavernous sinus with a layer of epineurium. This is the fourth cranial nerve. Here, this is the fifth nerve. And here you see how it lies within the layers of the dura. This is the endosteal layer, and this is the interdural, the epineurium of the trigeminal nerves. And both these layers merge together. And when you are coming from the middle fossa, you peel this layer to enter into this region. This is just a view of the anatomy. This is the region of the Meckel's cave or the depression. So this is again the interdural approach, as I'm sure Max will cover in detail. So these are the two layers of the dura. This is once you peel when you open the cut into the lateral wall of the cavernous sinus, this is the view you will get. You will enter into the region of the trigeminal nerve. This is the region of the Meckel's cave. These are the various divisions. And this is where the trigeminal schwannoma resides. That is why the interdural approach to these trigeminal schwannomas is most appropriate and most comfortable, because you do not have any danger of damaging the carotid artery. So coming to the retrosigmoid, before that, quickly, little bit about trigeminal neuromas, which has already been covered. The important thing I would like to say is that the symptoms are very minor, and this is a very characteristic finding. So if you look at the patient's face, you will see that there is a hollowing of the temporalis fossa here, and that makes the diagnosis, you can clinch the diagnosis with that. So these are the types where there is a predominant middle fossa component, a predominant posterior fossa component, a dumbbell-shaped tumor with both a middle and a posterior fossa component, another one with a middle and posterior fossa component. Here there is a larger posterior fossa component and a smaller middle fossa component. This is a trigeminal schwannoma that is extending along the V1 right into the orbit. This is again another trigeminal schwannoma, which I did recently. Here you see the multi-compartmental nature of this tumor. You see here the carotid artery. I have gone inside because I know that there is a layer of dura protecting me from the carotid artery. And you can see I've removed the whole tumor. This is the petrous part of the carotid artery. Here you see how the petrous bone is completely eroded. And, the tumor actually makes way for you to enter into it dictates the approach, and it helps you removing the tumor. This is the V2, the maxillary division, and you see the extensions of the tumor down. Here you can see, you can actually palpate it on the roof of the hard palate when there is such a large tumor. This is the mandibular division going down here in the infratemporal fossa. Here again, you can see a swelling here in this region, which the tumor has made. So these tumors are multi-compartmental, and basically two approaches, the middle fossa approach and the retrosigmoid approach, are the most appropriate to handle these tumors. So this is the tumor. In 1992, how were these tumors approached? Two approaches were simultaneously done, a middle fossa and a posterior fossa. And here you can see the middle fossa removed first, the posterior fossa removed second by the retrosig approach. Professor Dollens described this approach in 1995, the epidural approach to trigeminal neurinomas. At around the same time, Professor Goel described this interdural approach to trigeminal schwannomas. So this was the approach where it was approached from the infratemporal fossa without forming a craniotomy. This was the region of the tumor, and this was approached just on the basis of understanding of dura. And later on, we expanded this to form the basal lateral subtemporal approach. So this is the tumor which was operated just using this intradural approach, peeling the layers of the dura and removing the tumor. Here you can see the foramen ovale was widened, and just by widening that and making a dural incision, the tumor was excised without doing an craniotomy. Actually, this is another one recently done. You can see that this is the region. The bone has been eroded here. You just widen the foramen ovale and you enter into the tumor. So this is one of the largest experience in the world of trigeminal neurinomas, and the whole approach is based on this anatomy of the trigeminal schwannoma. So they have characteristic anatomical relationships. The petrous apex is eroded. The cavernous carotid is displaced medially. It is confined to the dural space of the lateral wall of the cavernous sinus, forming the basis of the intradural approach. In the posterior fossa, the tumors are generally intradural. The layer of the dura is extending into the posterior fossa, and sometimes you have to make an incision to actually enter into it. So it is either intradural or interdural. So you play with the dura in the middle fossa. In the posterior fossa, you either play with the dura or the arachnoid. Here, this is how the tumor grows. As the tumor involves actually one fiber of or fibrils of the trigeminal nerve, the other parts of the trigeminal nerve are actually intact, and it is imperative to preserve this. So this is the basis of the extradural approach, where you peel off the layers of the cavernous sinus and enter the tumor. Extracranially also can be removed with this same approach. You enter the dura, And it is actually a cranial approach to an extracranial tumor. You remove the tumor in the middle fossa or the posterior fossa and then go down towards the extracranial component. Now coming to the retrosigmoid approach, when would I do it or when would we do it? It's either when the tumor is exactly completely in the posterior fossa or there is a large posterior fossa component with a small middle fossa component. This is the indication. Here again, the Meckel's cave is widened. So I can get both these components straight from a retrosigmoid approach. This is the anatomy. We are all familiar with this. The retrosigmoid approach is our workhorse, and I don't need to give you too many details about it. And this is the petrous bone. This is the region of the petrous apex. This is the IAM. So the Meckel's cave is in this region. The trigeminal nerve will enter from here. This is looking at it from the retrosigmoid view. This is the petrous ridge. This is the petrous apex. This is the region of the Meckel's cave depression, and this is where the trigeminal nerve will come. The most important landmark while performing a retrosigmoid craniotomy is, of course, the mastoid and the asterion. And we usually do these tumors in a retrosigmoid. In a sitting position, it makes it very easy for us to do these surgeries because, you know, the gravity helps and the brain can be relaxed very easily. So this is the typical incision. This is the flap that is raised. And here you can see this is the region of the asterion. So the first burr hole will be made in this region. And here you have to go ahead and make a craniotomy extending till you expose both the junction of the transverse sinus and the sigmoid sinus. This is important because the trigeminal schwannomas are in this region. They are above in the, in the first part of the CP angle anatomy has been described by Professor Roton. So the rule of 3. So it is the trigeminal schwannoma will be in the upper complex. So the first step would be to raise the cerebellum off the foramen magnum and relax the brain. So opening the cisterna magna, this makes the brain very relaxed, and then you can go ahead and approach the tumor. This is the anatomy in this region. This is the brainstem, the vertebral artery, the lower cranial nerve complex. Coming back to the trigeminal schwannoma. So here you see this is the region of the sigmoid sinus and turning into the transverse sinus here. This is the superior petrosal vein, which is one of the main veins that you will recognize by going into this approach. So once you have relaxed the brain, you can depress the cerebellum downwards and you will see the superior petrosal vein and you will see the schwannoma. So this is the view of the CP angle. And as Professor Roton has described, there are 3 complexes here. This is the upper complex, the middle complex, the lower complex. The upper complex will constitute the 5th cranial nerve and the superior cerebellar artery and the petrosal surface of the cerebellum, the tentorial surface of the cerebellum. The middle complex will constitute the 7th, 8th cranial nerves, the ICA and the petrosal surface of the cerebellum. And the lower complex is related to the suboccipital surface of the cerebellum, the lower cranial nerves, and the pica. Here you can see the sensory root, larger sensory root of the trigeminal nerve, the smaller motor root, which is more medial. This is the superior cerebellar artery. This is the 4th cranial nerve where is entering the tentorium. This is the region of the Meckel's cave. Here you can see the 5th cranial nerve entering into the region of the Meckel's cave. So what happens when you do trigeminal schwannomas? So this is where they are generally located. You can identify and separate the tumor from the nerves because it arises from some fibrils of the nerve or a single fibril of the nerve. A part of the nerve will still be preserved. So the goal of the surgery is to preserve these. So you can preserve function of the trigeminal nerve. And the Meckel's cave is also widened here. So straight from here, from this posterior fossa, you can remove the middle fossa component of these tumors. And you can get both of them by using a single approach. This is the 3rd nerve in the superior part. This is the 4th nerve. You can see it coming from the posterior aspect of the brainstem and going into the cavernous sinus. This is entering the roof of the cavernous sinus. This is the superior cerebellar artery. Now, when you look at it from top, here you see the cerebellomesencephalic part of the superior cerebellar artery. And sometimes it comes here in close relation with the trigeminal nerve. So when you depress the cerebellum, this is how you'll see. This is the 5th nerve. This is the 4th nerve. This is the lateral part of the brainstem. And this is the superior cerebellar artery. And again, so this is the area where the trigeminal schwannoma will reside when you're doing a retrosigmoid approach. So this is the vein that you see, the superior petrosal vein. This is the trigeminal nerve. This is the 5th nerve. So the trigeminal nerve is more medial. And this is the area where you have to work in. Here you can see the 4th nerve. This is the region of the Meckel's cave, which will be widened. So once you remove this component of the tumor, you can enter into this widened Meckel cave and remove the middle fossa component of this tumor, as I will show you in some images shortly. And this is just a view from the side. Again, you can see the fifth nerve as it is coming out from the pons. This is the 7th-8th complex. The fifth nerve, the 7th-8th complex is the lower cranial nerves. So this tumor, you see the large posterior fossa component and a small middle fossa component. It's a straightforward approach. This is our workhorse. This is a straightforward approach to the trigeminal schwannoma. Remove the posterior fossa component, enter into the Meckel's cave, and you can remove the middle fossa component. Here again, another tumor. You see these tumors tend to have multiple fluid levels. Again, straightforward. This is a small middle fossa component, and you can straight come in and remove this. This is again a tumor with a small middle fossa component and a large posterior fossa component. Again, we can approach this by a retrosigmoid approach, as you can see here. The reason being that the Meckel's cave is completely widened, the petrous is eroded. So from the retrosigmoid view, you can remove both the components of the tumor, as you can see in this image. Again, another tumor with a little largish posterior fossa, middle fossa component with a posterior fossa component, but it is quite cystic, and this was also easily done by going through the retrosigmoid approach, and you can see that the tumor has been excised. So to end my talk, the retrosigmoid is a simple approach to reach these tumors, and it is very eminently possible. And the middle fossa approach is another important approach for doing these tumors. So to understand the anatomy of the trigeminal nerve and how it relates to the dura will help you dictate the approach. Thank you very much. And before I end, I would like to invite all of you to Mumbai in August for our conference. And please write to me if you need more details. Thank you very much.
Thank you, Abhidha. There's one question that I don't know about asking. How to take care of the bleeding that comes from the peroneal venous plexus while splitting dual layers? Also, Professor Sami will
What's the
answer.
question?
Yes. So
yes.
Yeah. So the venous plexus is the bleeding will be more significant when you breach the inner layer of the dura. Within the dural layers, as the tumor has expanded, it has already taken care of most of the venous plexus. You will have the bleeding once you remove the tumor. Once you remove majority of the tumor, there will be bleeding. And all you need to do is pack it with Surgicel and gel foam, and it will stop within a specific time.
Professor Sami, the question was how to take care of the bleeding that comes from the peroneal venous plexus while splitting the dual layers.
Yeah, I mean that's a common thing, when you do subtemporal or interdural approach, and there's so many variations of the vasculatures there. So as was mentioned by Abhidha. Yeah, you compress that with gel foam or fibrillar. What I found recently, I mean maybe 2-3 years ago, is very effective. It's a Surgicel powder. So you spray it, it's a powder, and for cavernous sinus bleeding or subtemporal or interdural, because you spray it, so it spreads right away, and before you even compress it with cottonoid, it takes care of the bleeding. That's one of the new additions that I added to my surgeries. Very effective.
Any comments? Thank you, Abhidha. We can continue with Maximiliano.
I just have a question about Mumbai in August. How's the weather in Mumbai in August?
It'll be the rainy season, but the weather, it'll be just rainy, but the weather is okay. It's not too hot. It'll be actually, but we welcome you, and I will send you an invitation soon.
Thank you. Honored.
Thank you again. Maximiliano, you can share